I made another case. Okay, 43-year-old male patient presented with A&E following an RTA with his wife 8 months pregnant. First pregnancy. She is okay. Findings are suggestive of splenic injury. Not here. It actually happened in the same story, not in this hospital. So necessitate for the splenectomy, the consultant surgeon decided to go for a splenectomy and brought the patient immediately to the theatre and with the spleen and the splenectomy, injury is fine, everything is done, and resuscitated and the patient ICU, patient perfectly uneventful recovery, and we send the patient to the theatre. During that time I was in MO anesthesia. Okay, we sent the patient to the ward, and day 4, day 5 only identified patients not moving the limbs. Not moving the limbs. It means both lower limbs. Day 5 or day 6 identified total paraplegia patient. The sensor level around T10 or T11. Total paraplegia. Understand? So I saw again I met the patient again maybe after 1.5 or 2 months time. So the patient's coming with a wheelchair. Mother and the patient with the wheelchair is holding the baby. Okay, so the mother delivered first pregnancy to see the baby, to see the father with paraplegic father. I don't know whether he is still alive or not. Here, the missing part, I'll remind you later. What has happened? Right. Case 3. 56-year-old male patient, RT1 admission, BP is low. Fast scan negative, no external bleeding or no internal bleeding suspected. Okay, so because of BP, low BP and high pulse rate, thinking that some internal bleeding somewhere, fast scan negative, chest X is normal. Okay, air is okay, no hemothorax, nothing. So thinking that patient somewhere is bleeding, so pump again and again blood products, patient died. Okay, simple thing is, they have done a trauma series, X-ray pelvis, missed the bad pelvic fracture, and that's a retroperitoneal bleeding, extraperitoneal bleeding. And that simple pelvic binder could have saved the life. Simple pelvic binder. Okay, this is something. Case 4. Road accident, hypotensive, distended tendon abdomen. Road accident, hypotensive, distended tendon abdomen. What to do? CT, or laparotomy, or more fluids. Any other response from your CT? Yes. So, but patient, instead of doing laparotomy, patient sent for CT. Okay, patient arrested at the CT room. Okay, these are the very crucial decision making. Go by systemic assessment with the guidelines. Okay, we can serve the patient. More than serving the patient, we can serve ourselves. Understand? Right. We will come back. Polytruma. What do you mean by polytruma? So multiple traumatic injuries. Okay, at least 2 systems involved. At least one system is a life-threatening injuries. Normally we come across this one. Okay. Common causes road traffic accident, fall from height. Commonly it happens, and blast injury some time back, but still not common. Again, crash injuries. So commonly we have fall from height and road traffic accident. So high mobility and mortality. Just imagine having a knife cut, blade cut, simple injuries. How traumatic it is for us. Okay, so having a multiple injuries involving multiple system. Okay, just imagine the trauma and patient mindset and the family or relatives mindset. Okay, patient physiology, right? So examples of polytrauma is head injury plus chest injury, pelvic fractures, and chest injury, abdominal injury as well. If we are not responding to that golden hour within minutes, no point of doing anything for it. Okay? So the priority is identify, stabilize and transfer. Transfer means from A, I tell you about. Not to transfer in different hospital. Okay? identify, stabilize, and do something. So do what matters most first. Goal of management for a polytrauma patient: rapid assessment, early resuscitation, prioritize life-threatening injuries, and then day-to-day care. Okay. So whenever the polytrauma patient comes, do no harm. Do no harm. Rather doing better, if you are doing bad thing, better just refrain from doing the bad things, right? So do no harm. Right. In terms of polytrauma, everyone talks about primary survey, secondary survey, something like that. Everyone knows the name primary survey, secondary survey. But no one knows how to do it properly, and no one does. If I say honestly, no one does. Right? What is the purpose of doing a primary survey? Simple. To identify the life-threatening injury and quickly respond. That's it. That's all. Life-threatening injury. Primary survey. See, forget about the secondary survey. So again, ABCD, everyone talks about ABCD, all the sessions and lectures, ABCD, ARA, breathing circulation, receptive exposure, everyone knows. Understand? Listen. ARA assessment, breathing assessment, circulation disorder. Out of these all 5, forget about the E for the time being. Okay, A, B, C, D, E. In our setup, to our AME, in your experience, if a patient comes, which one is more compromised, A, B, or C? With your experience, tell me. Do you get a patient with a compromised airway or compromised breathing or circulation? Commonly. Most commonly C, circulation. Then B, then A. Understand? Do you get a patient with a completely obstructed airway with a full of foreign bodies or something blah blah and vomitus or the blood in the throat and or facial injury? Will you get that patient? Yes, as a dead body. Okay? Yes. But live patients, in our setup I am talking about, right? So, in our setup we get the C, most commonly C, B, A maybe. Okay? In the other way. Right? ARA. Quickly talk to the patient. If the patient is talking, that's ARA is better. No? That's right. That's one scenario. We are talking to the patient is not talking at all. Or snoring and silence. Something is ARA or head injury. 2 options. No ARA at all or no GCS. We have to quickly respond. We'll see that practice. Okay. Or in between patients, okay, talking and trying to produce some voice but couldn't. That is a dangerous part. That is a dangerous part. Patient still alive. Okay, everything is okay, but trying to tell something but patient is unable to tell. It means something here, problem. Okay, something. Right. And assess the ARA. Talk the patient. Just look at the face and neck injuries. Okay, palpate and see if there are any crepitus. There says laryngeal injury, tracheal injury, can go subcutaneous emphysema, blah blah. Very uncommon in our hospital. And if a patient, it happens like that. Anyway, it will not reach to the hospital. Like, understand? That's now our setup I'm talking about. Right? And then, right now you have identified the patient's ARA is patent. Perfect. Is that enough? Is that enough? We should assume it can. Okay, in about 10 minutes or 15 minutes later, can compromise. Say for example, patient airway, but patient having neck injury. The patient is talking, but there's a large laceration here, bleeding inside. Patient is lying supine, so it will bleed inside. Blood will go inside. It will block the airway, aspirate. Understand? Burn injury to the neck and face, nose and mouth, around mouth. Okay, now perfectly alright. Patient is talking. Maybe half an hour or 1 hour later, edema and compromise ARA. So you have to anticipate that. That's a simple thing. And breathing. Again the same, look, listen and feel. By looking at the patient itself, we can tell whether the patient is okay or not, or properly breathing or not. Okay. labored breathing, patients okay talking, but labored breathing, try to do something that it means something's chest is problem. Just open the chest and see whether it's a equally expanding chest, or one side is moving, or there's a obvious fracture, or the flared segment moving the ribs ups and down. Okay, so that part we can easily identify. Right. What's the purpose of primary survey? We are still on primary survey. Identify the life-threatening injury and do whatever the necessary things on that moment. It will prevent the life. Okay, it's a preserve the life. If you think a chest injury causing low saturation, are you proceed with doing chest X-ray or not at this moment? No. If you think chest injury, saturation dropping, patient is telling severe chest pain, or if you think that AIT is low, no chest X-ray, no chest X-ray. Go ahead with intervention. Okay, ICTP insertion. Okay, needle thoracotomy. Commonly we do ICTP insertion. We can remove the ICTP after hour or days or weeks. Okay, don't wait for the chest X-ray. Go for the intervention. Circulation again. Okay, if the patient is bleeding outside, of course, we have to stop that by putting a external pressure or bandage or tourniquet is controversial anyway, like that. If it is suspecting bleeding inside, low BP, complaining of severe abdominal pain, tachycardia, okay, bleeding inside, we have to quickly respond for that. Okay, so if you can only feel that dorsal pulse, it means at least patient is 90 mm mercury blood pressure. If you can't feel the dorsal and if you can only feel the radial pulse, means it is around 80 mm. If you can't feel both upper limb and lower limb, it means no blood flow to the limbs. Femoral pulse you can feel, okay, there's a, you can feel or not, yes, you can feel slightly a small pulse, okay, then 70. Carotid if you can feel 60. That's normally we can assume, but before that we get the blood pressure and see. But when the patient comes to the hospital or A&E or wherever, we can immediately tell, okay, what could be the internal environment, right? But you can't feel the pulses peripherally, or carotid pulse, BP low, high heart rate, no external bleeding, fast scan negative. So you just palpate and see the pelvic. Always remember, don't forget to just palpate and see the pelvis. That is the part, missed one case. I think the third case I talked about. Okay, if you are suspecting, until proven otherwise, apply pelvic binder. You know how to apply the pelvic binder. Okay, until proven otherwise, put a pelvic binder. Okay, when you are assessing the airway, until proven otherwise, assume patient having C-spine injury. Until you do the trauma series image, C-spine X-ray or the CT, don't think that patient is okay. Put a heart collar, Philadelphia heart collar, and you know how to. There's a different discussion, that manual inline stabilization during the assessment of the airway, or putting the LMA or airway inside, or intubation, anything until proven otherwise. Always remember, when you get a polytrauma patient, until proven otherwise C-spine injury, until proven otherwise vertical injury and pelvic.